Hello and welcome. This next case you're about to see is an implant replacement for an upper bicuspid for a young Polish woman who recently arrived in the United States. Yasia is 26 years old, in excellent health, takes no medications, but does smoke 3 packs of cigarettes a week. In Poland, she told me that she had had her teeth cleaned once in her entire life. At the age of 26 years, this woman has only had her teeth cleaned once. She had tooth number 5 extracted traumatically about 6 years ago and never had it replaced. She's just excited to get her mouth in better shape. She is a very attractive young woman and finds it difficult to smile without putting her hand over her mouth. So today we'll see this single implant replaced.
What you're looking at is Yasia's upper right first bicuspid, tooth number 5, which had been missing for some period of time. Please note that both of the teeth on either side of the edentulous site are virgin teeth, so an implant is the correct choice. We're trying in a vacuum-formed stent, which was made in our laboratory that we'll talk more about later as we proceed with the case. We're probing now with a periodontal probe to look at the thickness of the soft tissue. Please note that it's about 2 millimeters, 1 to 2 millimeters in thickness, and that's how much soft tissue you usually have covering the bone. It's the minimal amount of tissue. We're looking at the keratinized tissue and evaluating that. Mesial distally, we're probing. We need approximately 7 to 8 millimeters to place a single tooth implant, ideally 7. Palatal incision is made from line angle to line angle from the second bicuspid to the distal of the canine. Sulcular incision is made distally, and on the mesial we're going to take our 15C and we are going to make also a sulcular incision, but we're going to make a small vertical incision in that area just to get access to the bone. The purpose of the vertical incision is so that we don't have any recession on the canine because we're right into the aesthetic zone. In a more posterior area, it's not as critical that we're concerned about this. We're just redefining our incisions with the 15C scalpel, sulcular, palatally, and then we will end up going one more time down the mesial aspect so that we can reflect that little mini flap toward the buccal. The secondary instrument I use is an Orban, which I use just to redefine my incisions. I use that to refine to make sure that we're down to bone, as well as to help to elevate. We also frequently use a 4R, 4L Columbia curette, and we're slowly pulling the tissue off of the bone, making sure that the periosteum is connected. That's the small end of a Pritchard periosteal elevator being used to elevate the mini flap toward the buccal so that we have access to the bone. In this case, we decided to make a mini flap so that we have access to the bone. We did not have a CAT scan in advance. I wanted to make sure that there are no undercuts, which frequently do appear in the area of the first bicuspid. Utilizing a Gore-Tex suture to tie back the flap toward the buccal, and we're just using this as a second pair of hands. Suture will stay in for the duration of the surgery, just allowing us better access. One of my favorite burrs is this finishing burr made by Brasler. A lot of people refer to it as a Neumeier burr. It's sort of a football-shaped finishing burr, 12 fluted, and it's an all-utility burr. I'm using that now to degranulate the bone. We don't want to have any soft tissue next to our implant. Periodontal probe again shows that we have 8 millimeters. We'll be placing a 4 millimeter implant. That leaves us 2 millimeters on either side. This is the initial spade type drill that we use just to make the hole. It's in our burr kit. It happens to be a 3i burr kit. It's the first burr that we use just to perforate through the cortex. 2 millimeter twist drill goes in, utilizing the stent as a guide, and we're going to make sure that we're in the right position. When we do our surgery under sterile technique in our office, we just feel it raises the bar a little bit. Going down about 6 millimeters now, we'll probably go to the 7 millimeter number, and then we'll take a test x-ray to make sure we're down. We're now down at about 10 millimeters, going in with irrigation at 1200 RPM. We put our guide in, and we look at the position of the implant, and it looks relatively okay with the stent in place, but a check x-ray is needed. Check x-ray shows that the implant is shy of the sinus and is drifting a little bit toward the bicuspid. We want to angle that implant a little bit more mesially, Okay, the angle is too far distal. We're going to change the angle with our 2mm twist drill. Frequently we'll use an osteotome to help with that as well, and we'll probably get an osteotome out in a second to do that. See the copious irrigation that we're using right now with the 2mm twist drill going at 1200 RPMs. So we've tried to change the angle a little bit at this time. This is the osteotome going in. I frequently like the osteotomes. I'm tapping very, very gently, not hard, more just to change my angle a little bit. This angle is still a little bit too far to the distal according to this. And the osteotomes have various marks that correspond with the burrs. We're down right now to about 11 millimeters. We'll take another check x-ray in just a second just to verify our position. This is the second size osteotome that's a little bit larger in diameter. I like the osteotomes because they're a very gentle way of expanding the bone, to make sure that we are. We also use it not only to expand the bone, but to verify our position in relationship to the sinus, and we also use it to compress the bone. Frequently, we can change type 3 or 4 sites into type 2 or 3 sites. So by compressing the bone, you have a more dense bone to place your implant. The density of bone is related to the success of the implant. We've changed our position, and what I'm going to do is I'm going to try to change it a little bit more by using this tri-spade drill just to angle it a little bit more toward the mesial. I cannot overemphasize the importance of taking check x-rays in the middle of your implant surgery. Digital films have been a great boon to implant surgeons. It's very quick, in just basically 10 to 30 seconds we can have a view of the position of the implant in relationship to the teeth. When we used to expose implants, it took quite a few minutes to do that, and oftentimes that step was omitted. Today I never place an implant without taking a check film. I find it's much more accurate way to go. And we're just right now just re-drilling the site. We're down to almost 11 millimeters. We have not perforated the sinus. We're shy of it. Please note that the papilla is still there. I'm going down now with a periodontal probe, which is smaller than our 2mm instrument, and it shows where we are. And we're just pushing that up a little bit. We are going to be using a tapered implant, and I'm utilizing the quad drills, my 3i. This is for the 325mm implant. You notice it has a purple band, and we put that to place. At this time, we'll probably place our guide in there to make sure we're in the right position, and there's our guide. And it's color-coded, purple to purple. And notice that's in perfect position in our stent. And a stent we can look at three-dimensionally. We're now going up to the blue quad drill, which is corresponds to the 4mm implant. And what you'll notice is that we're sinking it so that the implant is going to be just at the crest of the bone. Okay, our position is verified, and we slowly pull the drill out. Very often we can pull bone out with this quad drill. In this case we have not. It's recommended to go in at approximately 1200 RPMs with copious irrigation. Here's our countersink so that the implant will be able to be flush with the surface of the bone, and that will be able to get the cover screw down. And we're doing that in this area for cosmetics. I would like to bury the implant in this area so we have a nice emergence profile so that the implant is a little bit beneath the crest of the bone. Here's our quick connector. We're picking up the implant. In this case, I believe it is 4 by 11.5 millimeters. It's an osteotype surface. This is a hybrid implant, and you can see it's tapered. It's a very aggressive cutting pattern, and it'll follow the osteotomy site right in. Most likely this implant will torque out. We're going in at 50 Newton centimeters, so the implant should lock out right before it reaches its depth. The implant is a little larger than the diameter of the hole, and when it torques out, it shows that we have very, very good retention of the implant, good integration. It's torqued out now. I'm going to have to hand ratchet that to place the hand ratchet on, and we'll probably go in with torques ranging somewhere about 70 to 80 Newton centimeters. We're torquing that in, and there's a good feel for that. You can feel where the implant is. That's a very good picture of the implant placed slightly subcrestally. You can see that we're slightly beneath the crest of the bone. In order to get our cover screw or our abutment in place, we're going to need to do a little bone profiling. These little instruments made by 3i we'll remove a little bit of the bone around the surface of the implant without touching the implant itself. And what you're going to see now is we're twisting it back and forth, removing just a little bit of bone, so we'll be able to get a cover screw into place. One more thing that we often do is we'll place these implant protectors in, and we can use a rotary instrument to profile the bone there. And what you're looking at is an instrument that is made for the 4mm implants. It will flare to 5mm. It's a little larger as you move toward the instrument. And at 500 RPMs for the irrigation, we move just a little bit of bone. You can see that there's a little bit of a profile around that implant so that the button will be able to seat. Because this implant did torque in at 70 to 80 Newton centimeters, I feel very comfortable placing an abutment at this time, and it'll save the patient a second surgery, and we'll be able to move on a little bit quicker to our final restoration. We're moving a little protector, and there's our abutment, which is a 4mm abutment. It flares to 5. You'll notice that it'll lock on. It's also, you notice that there are little marks on the top of the abutment. Those little marks correspond to the diameter of the abutment, the profile, and we are going to placing that end-coat abutment on that area so that we'll be able to take an impression directly of the abutment and know the position of the implant. Because we've moved the flap from the palatal to the buccal, we have an excess amount of soft tissue. This is a good thing. I call it a non-surgical connective tissue graft because just by replacing the flap from the palatal to the buccal, you add a significant amount of soft tissue to the labial. Actually, in this case, we have too much, so as I'm pulling it out, I am just thinning the internal aspect of that flap. Utilizing a Gore-Tex suture, we will suture distally, mesially, and we have that small vertical to close. By performing the surgery in this manner, we don't cause any recession on the mesial tooth. Here's the second suture going in. Okay, you see we're coming in from the buccal, and then we'll tie that off. And then this is a gut suture that we're using just to close the vertical. I usually close the verticals with 1 or 2 gut sutures. The reason I use gut here because this vertical heals so quickly because of the alveolar mucosa in this area. I don't want anything to pull for this patient. So I'll place 1 or 2 sutures on the mesial, and then the patient will be able to go home, and she'll be relatively comfortable. I called this patient the next day. She had no pain. Spoke to her a couple weeks later, and she still had no pain. And she healed relatively uneventfully, and despite not having much dental care in her life, this was pretty much a non-event for her. And we'll allow that area to heal, and you can see the end-coat abutment is picking up as slightly above the tissue. We'll want 1 millimeter of it exposed. So here's the patient prior to treatment, and then here she is with the end-coat abutment. If the tissue does not shrink a little bit, we'll place a longer abutment on. Here you can see the abutment down to the implant, and the implant slightly perforating the sinus, approx 1 millimeter on this case. And that's about it. The patient will go on to heal for another 3 months, and then we'll take an impression and complete the restoration.